All right. It is Thursday morning and we can get started. Like I said, my name is Sophia Sa and I'm here at the EOHHS. Thank you for joining us today. Just briefly go over our agenda. We're going to review the rate setting methodology, the training curriculum, some updates since the last meeting, and our next steps. Next slide. We will be moderating will be Dustin and Jillian from Guidehouse. Our speakers for today will include myself and Kiavin, and then also Claire and Dustin from Guidehouse. And then just a reminder of the ground rules. This is recorded. We're going to be respectful of each other and our time. And if you have any questions, you can either raise your hand or put in the questions in the chat and we will address them. So to start, we're going to go over the rate setting, and I believe Claire will handle this portion.
Yeah, thank you. Good morning, everyone. Happy to be here with you all. So yes, as Sophie said, my name is Claire. I am an associate director with Guidehouse, who is a consulting firm that is then helping develop the specific CFCM policy as well as rates. We just over background, so you know who you're talking to. So Guidehouse as a firm, we've actually done rate setting in over 15 states and growing, and also have done home and community-based service, just policy design and consulting. And I think the last map I saw was 20, but I feel like there's some states I've worked in that aren't even on our map. So just becoming more and more prevalent, as well as more of a need here. So, I've actually recently, in the last 6 months, I think, been involved in about 6 different rate studies with a whole slew of services. So not even just specifically case management, but a whole mix here. So quite a range of different expertise and background. So just before we dive into the actual rates themselves, so just one caveat: when we are developing this rate methodology as well as the policy, there are specific federal requirements for HCBS rate development that we want to make sure we are following, and therefore we can get the proper approvals from CMS at that time. So just number 1 on the screen here: payments for waiver services must be consistent with so 1902 A30A, long winded number there, of Social Security Act. So payments are consistent with efficiency, economy, and quality of care, and are sufficient to enlist enough providers so that care and services are available under the plan, at least to the extent that such care and services are available to the general population in the geographic area. So we put in bold there the efficiency, economy, and quality of care, because that is a big area we look at in rate development. Again, we're trying to set rates that are prospective, right, going into the future. We'll also take into account that, you know, certain providers may have different costs associated with them, different delivery models, but trying to think about building that consistency and efficiency, because that's the type of questions that CMS is going to ask when we submit this rate plan. Also, plan must describe the policy and the methods used in setting payment rates for each type of service. So again, policy: how did we actually get at the methods and the rates? How do we get at the assumptions? We have to submit very detailed methodology surrounding each one of those components. And then number 2, so rate setting methodology must be reviewed and updated, if appropriate, every 5 years in accordance with the renewal cycle. So that's kind of why part of this overhaul, that we need this type of detailed review every 5 years. So some pretty big points there that we have to make sure we're hitting, so that CMS actually approves and is in agreement with the methodology, which CMS does approve this methodology, and so it has been vetted. And then the CFCM rate overview here. So Guidehouse has developed a monthly CFCM, so conflict-free case management reimbursement rate of $170.87. So the CFCM program budget and rate was approved by the General Assembly for SFY 2024, again, using the methodology that we'll show in the next slide. The rate accounts for estimated costs to deliver conflict-free case management, there's various components that go into that I'll give a general overview of. And then again, Guidehouse rate recommendations and calculations is supported by a rate setting method accepted by CMS. Again, being aware that we can't just throw things out there. I have noticed in all of the rate studies that I have been a part of with my colleagues that there has been a lot more scrutiny from CMS over the past, I would say, year and a half. They're also putting out a lot more proposed guidance about certain assumptions that can be built into rate methodologies. And so we're constantly monitoring those to make sure we're building in assumptions that are going to be approved. And then just the current versus future state. So number of service rates, current state for EAD, there's 3 separate. DD has 8 tiered rates. Future state, which was a policy decision as well as an agreement with the state that wanted to get to this conflict-free case management single monthly rate. And then instead of having, multiple different types of service descriptions based on that population or, across different divisions, we want this specific conflict-free case management model that is supported by that very specific policy. And Dustin's going to go through a lot of that specificity as well and how we got to caseload assumptions using those kind of specific requirements that need to go into that plan. So this very detailed slide. Sorry for anyone that thinks the font is really small, but we wanted to make sure we got you the right level of granularity in here. So conflict-free case management rate calculation details. So just a couple things to orient you to the slides here. And I do see some questions popping up in the chat, so not ignoring you, but we're going to kind of circle back to them at the end and answer them all in order. So just some key considerations in the box on the right there. So a 48-person caseload will cost approximately $98,000 per year, right? So what we're coming up with is we actually look at the cost of a case manager and figure out, all right, how much does that case manager cost to a provider just based on like pure salary, right? And then we actually build in a lot of different assumptions here that you're going to see in the big rate calculation on the left. And I'll walk through that in a second. So we didn't use the state's existing rates given the differences in service requirements and variance in rates. So we actually built this rate from the ground up. So, what we see a lot of the time is we go into states and they've had the same rate and they just inflate it forward every year by 1 or 2%, right? Which we always hear when we actually do full rate study design or provider engagement that inflation doesn't actually keep up with the inflation of my costs or wages. I think anyone who turns on the news or works in healthcare specifically knows that inflation has gotten pretty crazy, right? So, but there's different types of inflation that need to be taken into account as well. So there's wage growth, there's cost of buildings, there's cost of food, there's cost of gas. So all different assumptions that we actually do build into these different individual rate components are taken into account instead of just taking an existing rate and moving it forward. And then the CFCM rate considered quite a few things here. So case manager and supervisor salaries from the U.S. Bureau of Labor Statistics. And I'll actually shift gears to the actual model itself because I want to talk about just on the column on the left here where it says center. So you're going to see some categories that we refer to as wages, supervision, admin and program, transportation. And so those are all related to different buckets of cost that we want to make sure that we're, taking into account when building a rate from the ground up. So we kind of call it a building block approach. So in your top boxes there, wages, you're going to see that we actually look at the hourly wage for a case manager. That's leveraging Bureau of Labor Statistics wage for a community health worker. That's already been inflated by roughly 14.27%. because the time at which the rate was developed in comparison to rate implementation, right, when this rate's actually going to take effect. There's also employee-related expenses. So we understand when you employ your staff, you're not just paying for their hourly wage, but there's benefits that are taken into account. So paid time off, holiday, sick time, vacation, health, vision, dental, retirement. So they're all different components that are built into that percentage that we actually apply on top of the individual wage. So you'll see that for this specific wage of $28.40, that's an additional 25.9% that's added on top of that hourly compensation, which takes you to an annual wage of about $74,000 salary. Not the only thing that we need to consider when thinking about service delivery. There's also supervisory time, right? So the number of supervisors that actually have to oversee the case managers delivering the direct care. And so there's a wage for that supervisor, and there's also that specific employee-related expense, or ERE, that again account for the paid time off, the health, vision, dental, again, everything that I kind of commented on. But however, our supervisors, we don't usually build in that they spend a full 40 or 30-hour work week solely supervising staff. And so that's where you're going to see that supervision hours per week of 8. So assuming that 8 hours of their week are spent actually directly supervising the case manager staff to oversee this service delivery. And then we have an assumption of a 1 to 10, or a supervisor ratio of 1 supervisor overseeing 10 staff, to account for that kind of how we split up that supervisory time. Then we also account for admin and program support. So this is all of the indirect cost or indirect overhead. So it's not just you paying staff, it's also the various indirect costs that you have to pay for to run a business, right? So that's going to be your front office staff. That's going to be liability, taxes, insurance, building and equipment costs. It's going to be additional supplies. So all of that information is built into that 10% plus 15%. So really 25% we're adding on top in relation to direct care costs to account for that indirect overhead. I will just comment, admin and program support and indirect costs is actually an area in which CMS is starting to pay particular attention to, and not necessarily for case management just yet, but for they actually recently released a proposed rule related to these costs for home and community-based service related to in-home. So things like homemaker personal care, where they're actually capping the amount of indirect costs that can be built into rate models. So that's still in the proposed rule state, but if it goes through, consulting firms like Guidehouse and the state won't be able to submit rate models that have a higher than their capped percentage. And so we're trying to be mindful of that as we develop this rate methodology as well. And then the last thing is basically we also added in transportation, knowing that case managers actually have to travel out into the community to provide this service. And so you'll see the kind of a weekly mile assumption, and then we use an IRS mileage of 62.625 cents times the mileage to get to that weekly number. So all of that information is added up. So the direct wages, the supervisory time, all of the indirect costs, transportation assumptions, to get to that total kind of annual cost there of that $98,000 I referred to in the beginning. And then you divide that out by your caseload, which again, Dustin's going to talk about in just a minute here, related to how did we get to that caseload. That's always an important number, right? How do you divide up that total cost? And then before we just jump to that next slide, just one thing I want to call out as far as assumptions. Some of these things are pulled from public benchmarks, as well as information related to like specific information related to the DD survey that was put out, as well as we looked at a lot of public benchmarks to make sure numbers seem to align. That 14.27% inflationary factor, we actually pulled that as well from public benchmarks to make sure that we're inflating that properly forward. So lots of different assumptions and areas that are built into here. But Dustin, I'll kick it to you to just talk about the caseload.
Thanks, Claire. So I'm going to quickly go over how the state calculated its caseload, which was, as Claire mentioned, used to support that monthly conflict-free case management rate calculation. And we wanted to present this information today just to help kind of the future case management entities just to understand the required level of effort to deliver this service. And as Claire mentioned, since conflict-free case management is a new service that has new requirements, the state didn't leverage things that it had in the past, and it calculated this 48 caseload looking at kind of those new requirements that it's defined. As you all may have seen, the conflict-free case management standards had some of those, and certainly there'll be some additional requirements that are posted at a later date. So the state went through the exercise of just looking at those requirements and assigned time estimates to specific activities to come up with that caseload. This calculation, as what we have presented on the slide, looked at both typical case management activities as well as the administrative time. And the state did also look at other state caseloads just to ensure that its estimate was appropriate. There is a lot of content here, so I'll quickly highlight just three things. First is the state is not mandating a 48 caseload, so this number does not limit case managers from going above or below this estimate. However, case managers must have appropriate caseloads or capacity that allows them to provide high quality case management according to the state standards. The caseload assumes that each participant receives 12 contacts during the year. So this, as we have highlighted on the slide, maybe by phone or maybe in person. And the last point I'll make is the caseload assumes that on average, participants will receive approximately 34 hours of support in a year. So as mentioned before, this time estimate may be higher or lower for certain participants just based on their needs and preferences. One thing I'll also note is that this calculation assumes that every participant receives an initial person-centered planning meeting every year. However, this activity typically will only happen once for each participant as they begin this new service. So this means that the allotted time for a participant in the second year may be less. But to be conservative, the state just assumed that initial person-centered planning would happen every year. So now we're going to switch over to training. And as Claire mentioned, I see a lot of comments coming through in the chat. We'll address all your comments and questions at the end of this presentation. So Kievan, I'll hand it over to you.
Thank you. Next slide. Thank you, Dustin. Thank you, Claire. We're going to go over the training methodology. So training for conflict-free case management will include a few different separate delivery formats, which include WellSky. WellSky is the system that we will be using, the electronic data system that we will be using, and then Inter-I, which is the assessment that we will be using as a separate training. And then we will also be doing a one-time orientation during the first quarter for conflict-free case management and HCBS final rule. And this training will be recorded and provided to agencies. WellSky and Inter-I will follow a train the trainer model. And as we better understand when people are certified, we will have more clear times and when we will be able to provide that. And the other thing that we wanted to really point out is that periodic program trainings, which currently
Yeah, it looks like you hit
yourself.
mute.
I'm sorry. I'm sorry about that. Murphy's Law, right? So periodic program trainings will be made available as they currently are, and that is what you should expect from us. What is Inter-I? Inter-I is we'll answer these questions at the end, but I'll just quickly explain what the Inter-I. The Inter-I is a assessment that is used by DHS social case workers to delineate high and highest and eligibility for
So can I
LTSS.
just jump in,
Yes.
Keavin, for
Yes.
folks in the DD system that are wondering what this is all about?
Oh,
This-
yes, the
Yeah, so this is,
yes,
the Inter-A is the
assist.
assessment tool that's used on the EAD side of the system, the elders and adults with disability side. The CIS-A will continue to be the tool that's used on the DD side for assessment of level of need.
Yes, yes, thank you, Brenda. Next slide. And I'm going to pass this off to Sophie Asa, who is also with EOHHS.
Hi, everyone. So I wanted to provide you all with a couple of updates from our last meeting. We will be updating a couple of rules and regulations. The reason for these updates is that they currently include something about HCBS, Medicaid, HCBS, LTSS case management, and going forward, that oversight of that will live within the EOHHS. So these are the list of regulations and each agency that will be adjusted to make sure that they align with the new conflict-free case management rules and regs that will be developed and put forth for CFCM entities to follow. And then some of you have already attended a couple of these, but we will be hosting virtual one-on-one listening sessions in October and November. This is an opportunity for us to have a smaller stakeholder meeting and to get some feedback from everyone after we present a general overview of the changes to the LTSS system and how it affects Rhode Islanders, and then reviewing the roles and responsibilities within conflict-free case management, and make sure we're getting feedback from you all as to to help inform that roles and responsibilities and different items that we make sure we're pulling in as we roll out this new system going forward. So then the next steps are around these certification standards. As we mentioned at the last meeting, they are posted for public comment until the 31st of this month. They are available on the EOHHS website. And if you have any feedback, please send an email to that OHHS email address, and please add the CFCM certification standards in the subject line. We will have our next monthly stakeholder meeting in November. And then we will be posting that roles and responsibilities list that I mentioned earlier on the EOHHS site soon. And we want to make sure that we're getting feedback from you all on those roles and responsibilities. And that will be done via our one-on-one meetings, which will occur throughout this month and next month. And if you have any other thoughts on the roles and responsibilities, again, please utilize that OHHS email address to send those in and submit your feedback. And then I think now we can transition to any questions from the group.
Yeah, and as we've done this before, so there's two ways to ask questions. First is chat. Second is raise your hand, I'll call on you. And then Jillian's gonna read your question from the chat and I'll call on attendees and we'll kind of just go back and forth. And then just some administrative items. So we will have to limit, or we will limit each question and answer to 3 minutes, just to make sure we have appropriate time for everyone on this call. And if we do run out of time for your question, place your question in the chat and we'll add it to the state's conflict-free case management questions and answers log, which is will be posted on the Rhode Island EOHHS website. And you can also see on the Rhode Island website that it has previous presentations and Q&A logs as well. So let's start with if you have a verbal question, Sam, you're up.
I'm coming. Hold on. Hi. Thank you. Thank you very much. The seeing the math is really helpful. And though everyone, of course, can quibble with certain assumptions, I think it's nice to see the rigor that you're bringing to the approach. A couple questions related to that. When I think about an agency setting up something like this, there's a fair amount of startup cost to get a program up and running before you really can have patients on board, or certainly up to the full caseload. There's management time to set up your billing processes, to post jobs, to hire people, to get your initial people trained. And then typically it takes months at least before you have enough clients in that you're at those caseload targets. So the first part of my question is, has EOHHS considered some sort of funding support for that startup period? Because there won't be PMPM revenue coming in right off the bat. And then my second question is kind of related to that, which is I don't see any allowance in the cost structure for what I think of as sort of like outreach. Like if you're in a business, you would say going out and finding clients who are interested in working with your program. And so I don't know if I've actually, something I've been wondering about the model from EOHHS is how are the conflict-free case managers expected to find clients, and how are clients expected to find them? To what extent are they getting assigned? To what extent is that a business function that the conflict-free case managers need to build out? Thank you.
Thanks, Sam. How about we start with startup costs? Someone from the state want to answer that one?
All right, 1 second. Like I said, John Bonin is here. We're just having some technical difficulties. He's joining.
No. Yeah, so there were not funds appropriated in the FY24 budget. So I think that's the most straightforward way to answer that question.
And then the second question was about the cost structure and if outreach expenses would be part of that.
So
Or is that
I
something?
can
Oh,
help
yeah,
to
go
answer
Maybe,
that.
and that's the question is like a little about the cost structure. It's actually more about the program design. Like how does EOHHS expect patients to be finding conflict-free case managers, and how do they expect conflict-free case managers to be finding patients? Like how do they envision that matching to work?
Sure, so I can help answer that. So we would not assume that that would be the responsibility of the conflict-free case management entity to do that. What the state will do is when it is the right time for a person based on, they've gone through eligibility. So certainly in the DD system, they've gone through eligibility, they've had their assessment, and then we would refer them to case management. So they start with the state process around eligibility and assessment, and then we would refer them to case management. People would be able to choose which case management organization they wish to participate in if we have more than one. And probably what we would do is want the if we have more than one case management agency to, give us a sort of one pager on, information about that agency, the people they're hiring, et cetera, so that we could make sure people, were able to make informed decisions about which agency they wish to connect with. But the state will provide those referrals to you.
Okay, thank you. And we are now going to move over to the chat. The first one is how many people with lived experience policies work at guidance? We have a lot of different experience here with, like 16,000 professionals. So kind of a broad, just kind of in general, a very broad array of experience and lived experience. The second question is, does the one rate apply to all services delivered within DD?
I think Brenda.
So I answered that. I think the rate methodology that was discussed was not for DD services, it's for the case management organization.
Okay. And then how did you arrive at 48 for a caseload? Seems high.
Yeah, I think that question may have come in before we got to that. So we did present on that slide.
Okay, so we're good there. And then what is the required educational level of the case manager?
Does someone from the state want to speak to that?
It's outlined in the certification standards that is posted on the EOHHS website. I don't know that off the top of my head, but it is in the cert standards.
I just did a quick look, Sophie, to see where we sort of landed with that. It's really designed more around competencies than around a particular educational level.
Thank you.
Let's switch over. Peter, you have your hand raised.
Hi, thank you for that. Brenda, if I could address this question to Brenda. Brenda, I've been at these meetings, and I understand that a lot of this is a work in progress, but I find that a lot of the times that we're having this discussion, we're approaching it from the standpoint of new entrants in the system and not really discussing how the 4,500 adults with developmental disabilities are going to choose. Is it going to be a choice? Is it going to be an allocation? Is it going to be providers working directly with organizations? I mean, frankly, I think if we describe this as a choice-based system, in some cases it would be artifice anyways. But I just wanted to try to get a sense of, as we're moving populations over into a new program, if we could start talking about it in terms of that transfer, as opposed to, I just turned 21, I'm entering the system. Because that's what really is going to impact providers the most.
Sure, that's a fair question. So you're right. So there's many people already in the system, and how would they sort of roll into case management? So we have not confirmed the detailed transition plan about that, but we believe it would be based on when a person's service plan comes up. So they would sort of roll in as new ISP was due, then that would be the time where we would refer them to case management to get that plan developed. Is that essentially what you're asking, Pete?
Yeah, I mean, obviously there's a lot of questions there. I just sort of wanted to reframe the question, but thank you, Brenda, that's helpful. But
And
again, at the end of the day, the questions that are swirling around in the provider community, I believe are, it's going to make a great deal of difference for the providers if they're, depending on the amount of different agencies that you actually get to respond to certification standards. If we're working with one entity, 2 entities, 15 entities, 20 entities, obviously it becomes increasingly more complex. So that's just something I wanted to put out on the table there, in how we form these relationships with the different groups, because that's a learning process for everybody involved.
Right. Yeah.
Yeah. Thank you, Peter. And we'll go over to the chat here. The question is, have you taken into consideration that some of us have federally approved indirect cost rates that are higher than 10%? I'm not sure if that's Claire, Dustin, or Steve.
Billy and
Yeah.
I can comment. Dustin, do you want me to go?
Yeah.
Okay. Yeah, so the indirect costs are actually in the model 25%, because we just split it out into administrative versus program support, so you can just see the differential of how costs are distributed. We did not take into individual considerations if your organization or provider group is over the 25%. However, just wanting to comment again on, these are prospective rates. We have to build in assumptions kind of across the board. If you have a specific nuance, I think you can communicate that up, but it is 25%, not 10%.
Thanks, Claire. Jillian, can you just take the slides down so we can see each other?
Oh yeah, that would, Dustin, can you?
Yep.
Brenda, I love that you want to see my face. Thank you.
All right, there we go.
Thank you.
All right, Annette.
Yeah, just briefly, I think that my question was misunderstood when I asked about lived experience. I'm just wondering if there is anybody building these models who has had to live as a recipient of services under this model. And this is the big gap that I see. And I'm an economist as well as a person, an adult with a disability. And I know that you can come up with all kinds of models, but unless you've experienced it, believe me, it's incredibly different. And this is a very scary proposition for us. So is there anybody building this from Guidehouse that is in the same kind of position? That's my question. Yep. Thank you.
Yeah, Annette, thank you so much for your question. So never want to insinuate that we're saying that we have the same exact lived experience as you or anyone else with a disability. We do have a huge group of colleagues here at Guidehouse that have been licensed clinical social workers in the field working as case managers. Not exactly the same, I know. We also have, parents with kids with developmental disabilities or disabilities. Again, not the same, and I'm definitely not trying to insinuate that. So there's a whole mix, but it's definitely not a one-on-one experience as with what you're going through as well. But we also do a lot of focus groups with different populations. So, and again, it's not exactly the one-to-one, and I completely understand that, but we are trying to get mixed perspectives, which is also why we want to make sure that we're bringing, people like yourself into these work groups to hear your feedback, to make sure we're taking in that.
Okay.
Thank
Thanks,
you.
Annette.
And the next question here is, will the slides be available after the meeting? Yes, all of the slides are always posted to the conflict-free case management website. The next question here is from Sam. That doesn't seem to account for any time for training staff, onboarding, team meetings. After PTO and holidays, staff don't work much more than 1,632 hours in a year.
That's okay. You don't have to answer that one. You discussed it after I put it in the
We're good? Okay.
chat. I mean, I still quibble with the numbers, but I get it. You answered it.
This question is, if you have smaller caseloads, how will you cover the supervisor cost?
Is that something you could speak to, Claire?
Yeah, I wasn't fully following, but let me just explain the supervisory cost component. So the supervisory cost doesn't necessarily respond or relate directly to the caseload. It's more of the number of case managers. And so we built it in as a ratio in comparison to that. So it's just additional cost based on how we divvy up a certain supervisor's time. If that didn't answer it, feel free to throw up your hand or.
Yeah, so Claire, this is Linda. I had asked that question.
Thank you, Linda.
And I really still don't understand the answer, so maybe I didn't ask it clearly. There's an
that's okay.
assumption of a supervisor for X number of conflict-free case managers. I think it kind of ties into Peter and Sam's questions in some ways about when you're starting out and you may only have my assumption, and maybe I shouldn't, is the day you start doing this type of service, you have to have a supervisor for that conflict-free case manager. There's no way, as you're building it, that you're getting anywhere near enough money to cover that conflict-free case manager supervisor. So that's really my question. So it goes to the fact that there's no startup, and there's an assumption that agencies who become certified as CFCM entities can cover that cost. And I just would say we're not going to have a ton of CFCMs in the beginning. I think there will be a lot of challenges to recruit. And I think you should just be thinking about where there might be some flexibility, where there could be some upfront, don't call it startup, maybe you get a little extra boost and when you take somebody on in the first year so that you can cover that supervisory cost in a different way. That's a big worry. If I'm looking at becoming an entity to do EAD, how do I do that and not lose my shirt?
Sure. Okay, so related to the startup cost piece. Yeah, thank you for that, Linda.
Mm-hmm.
Okay, thank you, Linda. Claire? Next question is, where is the time accounted for plan writing outside of the face-to-face meetings, support coordination, referral attempts, other troubleshooting, etc., involved in the plan development and monitoring?
Yeah, for the caseload calculations, what we tried to do is kind of bake in all those hours into those main buckets. So when we have like initial person-centered planning meeting where we had 8 hours, that kind of includes those activities to complete that general activity.
Okay. The next question we did respond, Linda, this one, but just kind of want to make sure, what is inter-I? Wanted to make sure you had that clear understanding, Linda. Brenda gave, it's an assessment used on the EAD side.
It's an assessment used on the EAD side, whereas DD uses the SIS.
Okay. So Linda, if you have any further questions, go ahead and let us know there. The next question is, will the state continue to use WellSky, or will they be merging over into human services that DHS uses now? Also, for those who have been trained on the inter-I, do they still need to go through the training?
The state will be using the same platform as DHS, Human Services, which is WellSky.
And then I think as far as I think you're asking regarding the trainings that the state's going to be providing on the Interi, if you've already been trained, I think that will probably be determined on a case-by-case basis.
If they're already trained, we shouldn't have to do training for them again.
Sure. The next question is, does PTO contemplate FMLA?
Yeah, I think if you're referring to the 200 hours or 5 weeks that we estimated, so that number was actually pulled, just to be consistent, was pulled from the rate study that DD did last year.
Okay, thank you. Next question. Will there be public comments allowed / required if any changes are proposed for the licensing regs?
So yes, that's
Yeah.
typical
Go
process.
ahead, Brenda. Yeah, for all licensing rules and regs, there is a built-in public commenting period.
Okay. Next question. Will the roles and responsibilities include how the MCO's health plans will be involved?
I can answer that one. At this point in time, the roles and responsibilities does not include the MCOs, but we will build that out as you're aware. We'll be transitioning into all of LTSS, shifting into managed care in the next few years, and we will build out additional roles and responsibilities to include that transition.
Thank you, Sophie. Our next question is, do the numbers, wages, expenses presented represent the cost of living and doing business in Rhode Island, or is it based upon surveys and results from other states?
Claire, we'll kick that one over to you.
Oh, great. It's a combination. So some of it is related to, again, like that DD survey that was completed last year, as well as some of it is kind of public benchmark data from one of the sources that we commented on as Bureau of Labor Statistics that does national as well as state specific numbers. And then also some other public sources for transportation looked at average miles driven within the state specifically. So all kind of a mixture, but again, trying to benchmark and make sure things seem reasonable based on survey response.
Thank you, Claire. The next question is, what changes will be made to LTSS qualification / application process?
I can jump in for that one, at least on the EAD side. The change would be that everyone would be using the Interi assessment. We're going to be using one assessment tool to allow for ease of application. And I don't believe there would be much changing on the DD side, but I can let Brenda speak to that.
That's correct, Sophie.
Okay, thank you. The next question is, when will the actual content of training be available for review?
We would like to hold a small group meeting with some of the stakeholders before we make that available, but we expect that to be available by the end of November, early December.
Okay, thank you, Kiavin. When will current plan writers know the timeline to end with current families and the process? Many families are asking questions.
So a lot of this is contingent upon, who we have applying to be certified case management organizations and how many we receive. Once we are ready to begin that process, people will be notified and we'll have lots of materials to help talk with folks about what will happen, help them to decide which case management agency they would prefer and the process to go through. We're just not there yet.
Okay, thank you, Brenda. Our next question is, in the new database, will you capture data on community caregivers, such as the caregiver's age and ability to continue in their caregiving role long-term? For example, caregiver in their 80s caring for an adult child with disabilities at home.
we will be capturing information about caregiver, when we're considering what folks' needs are and risks are, those will be questions that will be asked to better understand their particular situation and what their needs are.
Thank you, Brenda. Next question, during the certification process, when the CAP agencies are no longer doing the LTSS application, how is DHS going to keep a list of which CAP agency will get the client?
Can you say that
yeah,
question again? Because I'm not sure that. Can you just read that one again, Gillian?
Yeah, sure. So during the certification process, when the CAP agencies are no longer doing the LTSS application, how is DHS going to keep a list of which CAP agency will get the client?
I think that was a little bit answered earlier, where the client, as part of their eligibility process, gets to select which case manager they want to receive their support from. So it's the member's choice on which agency they want to be assigned to. So
Thank you, John. The next question from Heather, I think we've already responded to a similar question, but you're asking about the indirect rate, and you're saying that you guys have a 13%, and Claire kind of clarified that the indirect rate is a 25%. So based off of that information, was anything else needed, Heather? Okay, thank you. Okay, the next one is it presumed that the supervisor will carry a caseload? And if so, what is the proposed caseload size? That's the first question. Claire will probably kick this over to you.
Gillian, the presume that the supervisor will carry a caseload? That question?
Yeah, is it presumed that the supervisor will carry a caseload? And if so, what is the proposed caseload size?
That's not how it's built currently. If a supervisor is providing case management services as well, like as a true case manager fashion, then they would be built in as if they were a case manager. Now, I will say again, we're only assuming that a supervisor spends 8 hours doing supervisory activities, which is what's built into the model, and the rest of their time they're kind of other administrative or program support indirect costs are built into that add-on. So there's kind of two areas in which supervisory cost is built in, but they wouldn't get their own caseload in this model.
Okay, and then Claire, the second part of the question, I think we already you've already responded to something similar, but I'll just read it. The question is, does the model account for the program management functions of the supervisor? For example, budget management and monitoring, quality review of records, agency management meetings, working with HR on recruitment, hiring, etc.
Yeah. So that's kind of the part of like where we account for their costs in two spots. So one is in that supervisory add-on, which you're going to see in the supervisor bucket in that rate model. So we're kind of doing a ratio essentially. And then the rest of that kind of administrative type of cost related to their salary would be in the administrative percentage that we add on.
Thank you, Claire. Next question is, will existing service providers be able to be a part of the supported decision-making team for an individual being changed over to the CFCM agency?
Yes.
Okay. The next question is, how much travel time for case managers is built into the caseload calculation? Claire.
Yeah, so the transportation piece, we kind of just assumed that was kind of part of all these like case management activities. So when we have like annual person-centered planning meeting, we know there's travel there. So that time, that 4 hours may include transportation and the discussion with the participant, as well as any documentation that's required to support that process.
Thank you, Justin. Next question, how does this model relate to the present caseload of elderly clients? Do the elderly begin over again with DHS?
Yeah, I'll have to defer to the state on its present caseloads.
Yeah, it should not be a complete start over. There are updated requirements that will need to over time be created, such if they don't have a person-centered plan, that'll need to be updated. So for current clients, it'll be, you know, a transition as their annual assessment comes up, or it'll be a gradual updating to ensure that all the requirements that are within the conflict-free case management requirements are eventually filled for the client.
Thank you, John. The next question is, can CFCM agencies reject referrals or close to new referrals if they don't have enough staff? Will be especially important for conflict-free case management agencies as they're staffing up and conducting initial training.
Yeah, I can add quickly. I think the state can correct me if I'm wrong, but the state's still working through kind of what its process for referrals will be, and certainly that will be an aspect that it looks at when it comes up with this policy.
Okay. Jennifer had a comment, DHS does not use WellSky. They have been using human services since OHA switched over last year. So I don't know if there was a question in there.
DHS does use WellSky.
Yeah, that is the same. It's the version
Yeah.
of WellSky that's called Human Services. So it's the same. WellSky is the company. The Human Services is the name of the particular system that they built. So it is one and the same.
Yes.
Okay, thank you. The next question, to confirm IDD assessment / funding will be completed by the state and EAD assessment funding will be completed by the conflict-free case manager.
No, the assessment will be completed by the state on the EAD and the IDD side.
Yeah. And Adam, I don't know what you meant by / funding. So I don't know if you're able to provide some clarity there.
Well, just with on the IDD side, the assessment, the CIS lends itself to a tier level. So that is the funding level. So I was wondering if it was the same thing on the EAD side, that the inter-I was going to be the assessment and then the funding level was determined from that.
Yes.
Right. If they're in self-directed
Yeah.
or they're in, correct.
Yes.
Okay, great. Thank you. The next question is, what happens to those of us already receiving case management? Personal choice program is originally designed to give us choices and autonomy. This looks like it will take away our choices.
No, it's not designed to take away your choice. During the transition period, you know, if your current case manager becomes a certified conflict-free case manager and you want to stay with that case manager, you still have that choice. You know, the difficulty will be when we get to the end of the year and, you know, certain agencies may have decided not to continue as a conflict-free case manager. There will have to be some transitions and some new selections of providers. So that'll sort of be a over time transition that may or may not impact someone that's currently receiving services from an agency, depending on whether that agency decides to continue on as a case management agency under the new certification standards.
Okay, thank you, John. The next question is, can you expand more into the transition of all LTSS into managed care? Does this mean fee-for-service will not be an option anymore?
No, fee-for-service will still always be an option. You know, the new RFP that is going out that'll result in the contract for 2025 will have LTSS services will go into plan, but we will always have a fee-for-service component that we will have to manage.
Yeah, and I think this next question I think you've kind of already responded that, but just kind of want to read it to see if you have anything else to add, John. If all LTSS clients will be shifting to MCO in the next few years, what will be the future of conflict-free case management in regards to this model?
There's language that will be in the contract that will have the MCO's ability to contract with community agencies to provide the specific elements of the conflict-free case management for home and community-based services. And then they can then manage the medical side of the benefit package that was be included in the managed care.
Okay, thank you, John. The next question is, how many agencies have reached out or shown interest in becoming conflict-free case management certified?
I don't know if I have a number off the.
So
I know. You go, Brenda.
I was just going to say that we did do a request for information back several months ago to sort of see what our interest was. I know on the DD side, we did get interest from a couple of different entities, but really once the certification standards are out formally, right now they're just in draft. Once they're out formally, hopefully the beginning of December, then we will start to receive applications from entities interested in participating in that, providing that case management, and then we will know. So right now it was really just who's potentially interested, and some folks shared some potential interest or some comments or questions or things that could be barriers that we addressed and why we went to certification standards. So we won't,
to add on to
we
what
won't
Brenda
really
said,
know
there were
until
3
it gets out there.
agencies.
3.
Yeah.
Okay, great. I think we've already kind of responded to a similar question, but I'll go ahead and read that. If it is the member's choice on agency, what if the case management agency is at capacity and cannot accept the client? What will be the process? I think our response last time is that we're still kind of working through the process. And we don't have that. We don't have that to share today. The next, okay, let's see this one. How will the changes in LTSS and CFCM impact older adults receiving LTSS or waiting for a healthcare worker to start LTSS?
I think that was addressed a little bit earlier in the sense that we will transition individuals to receive case management, conflict-free case management, and be developing that client participation transition plan that will align with their reassessments and all of that. Thank you so much for everyone's questions. I do want to be respectful of everyone's time. However, I believe we are set to end at 11. And I know there are a number of questions that we did not get to. We will make sure to collect all of these questions and answer them. As was mentioned before, both the slides, the recordings, and these questions will be posted on the EOHHS website for people to view afterwards. And just want to remind everyone, those certification standards are still up for public comment until the 31st. So please go and review those and provide your comments to that OHHS email address that's on the site as well. Yeah, thank you.
Thanks,
all
everyone.
for your time.
Thank you.
For your day.
Thank you.